the month, we are all having, a little bit of time to put together a few other things and the team are getting. So, pocket of time to have have a small session as well as meet up and have a small meeting of it. So, welcome all everyone. And today we have two speakers from our hospital. The first speaker is Professor who is senior glaucoma specialist. He's based out of Urban IKEA system and he's done a lot of glaucoma work there. And I requested him to speak on some few newer, glaucoma therapies that have been interesting. They're not really new anymore because I think many of us are already doing these things. I know that Muktamal, the of the month, and maybe a few of us, Dr. Priyanka might already be doing, these, labels kind of, there's so many of these variations. So I thought it's worth going through them for some of us who don't do a lot of, these surgeries. And I've seen how glaucoma surgery has evolved, 5, 6 years back when I used to talk to people like Tanuj, Sujata, and Dr. Ramanji, and Dr. Pandra, they would outright dismiss being there for the cataract surgeons and not for the glaucoma surgeons. And just this last Sunday, I was in Jalandhar for a meeting, and there was a lecture by Dr. Pandra, and who went on to elucidate about the benefits of makeover or penetrating or full thickness glaucoma surgery. And I see that all the glaucoma surgeons have actively kind of, taken to all the various new surgeries. So I think the time of new surgeries has come. It's 90. Well, I was not too convinced because I've known IKEA was one of the big proponents of this thing, and he was speaking about it for the last 10 years, and just telling that maybe it's great for the medical scenario and for India, it doesn't make sense. And today I understand that most of our hospitals are primarily first offering their patients some of these surgeries rather than and keeping that as a reserve second step. And so interventional glaucoma is becoming the new buzzword for managing our patients better. And then we go on, and we have a second lecture from Dr. Fairwell, who is along with one of our fellows who will present a very interesting, couple of cases with the managing of the courses and how the things as well as other management, how we use it. And then we have two short 9 minutes talk by two of our fellows. So we start off because we don't want to go beyond 9 p.m. for the dinner. I promised everyone that we'll have another at 9 and we're already like 10 minutes. I wanted to start latest by 8 o'clock. So I invite we have, in fact, luckily we are joined by our guest moderator for the session, Dr. Zainab Maheshwari, who's going to be introduced by Shivam. Shivam has worked with Dr. Zainab and he was qualified glaucoma surgeon, and then we have two of our on-site, glaucoma surgeons. So I invite Dr. Mansi and Dr. Amal to come over and, lead a discussion for this talk. And we have Shivam introduce Dr. Devendra, who is a renowned surgeon. I met him and he's quite a prolific surgeon. And then we could go on to Shivam's talk. Hello, sir. Can you have your audience, sir? We also have one more seat vacant and we can't leave that vacant. So I invite Dr. Boli to come and join the time. Hello. Sir, are the slides also visible? Am I audible, sir? हेलो सर। अच्छा नहीं नहीं वो अनम्यूट हो गई हेलो
Hello, sir. Okay. Okay, sir. Just try connecting, sir. Okay, sir. Okay.
Really sorry for the delay. Actually, sir is traveling for his dinner conference, so he couldn't connect properly. He's still in the state. So he started asked to start the conference. Really happy to introduce my mentor, my guru, Dr. Devendra Maheshwari sir. And he is joining in this week, and we are very lucky to have on-site our great manager, Dr. Manish Madam, Dr. Martin Madam. And it's very exciting for me to see that such a great connected work is already being done in Dehradun. And it's like the fire of the MIT system is very burning, very brightly in Dehradun. With the MIT to take up the more a bigger stand in the development management. And I hope you can get a great insight from ma'am
And of course, sir, if you can join. Sir, am I audible?
can you hear me? Okay, then we
Yes,
start with the
yes,
slides.
I can hear you.
Can you give the lights, please?
Thank you. I hope the slides are visible. So we start with today's topic. The first topic for the today is the paradigm shift in glaucoma management and what are the view of MITs in our armament area. So this is my brief introduction. I think so we can this thing. So glaucoma is definitely a surgical disease, and as we know, capsulectomy is the gold standard, and it will stay the gold standard. But as well as we are seeing now, it is no more a gold. So with a high rate of complications, as you can see, and a high rate of like failures, like out of 50% failures quoted by a recent paper. So of course, the gold standard has been little bit dicey, and the post of management and the maintenance is there. Like you have to their massage, you have to do nasal dialysis, and they're bleeding, you have to face left face, and the push like trauma goes on and on. Like some nightmares can like still haunt you, like a blebitis or a leaking blood or choroidal distraction or even endophthalmitis. So change is the only constant we know. And you can look, as you can see in India, we have a very nice pattern shift as from ISRO going from bullock cart transporting the missiles from using a bicycle to ISRO going as a Mars mission and of course the new Vande Bharat. So if there's a pattern shift in our world around, so is the pattern shift in our global management. So yes, the mix is given the option and a way between the initial pharmacotherapy and laser therapy and the more investigational surgeries like a more invasive surgeries like a stab or a tube and all these things. And it's a very good option for a moderate to mild range of patients receiving a very nice response. So if we define mix, it's an arbitral approach with a medically traumatic and it is good moderate efficacy with high safety profile and rapid recovery. So it basically aims at the tracheal network, which is the seat for the maximum resistance to the aqueous outflow. So if you look at the collected channels, we know maximum of them are located at the nasal side. And if you look at the microscopic picture of the tracheal network, there is a part in the filtration area and there is a non-filtration area. So mix basically are just an angle network we have to remove, which is the seat of the maximum resistance to the aqueous outflow. So what mix has given us is the luxury of choices. So we are the evolution of the glaucoma management. It started in 1875, the introduction of pilocarpine, and now we have so many multiple options like Omni coming up, and all those device-based MITs which are coming up. So if we look at basically MITs, there are two types. Like one is the device-based, and others are the institutional-based, not the non-device-based. Okay? So device-based MITs, the big problem is that availability is in India is difficult, and of course the cost factor is there. So if we look at the combination form-based procedures, we have GAP, KD, microtracheotomy, EPSLAT, goniotomy, and bent abdominal goniotomy, maximum of which are being done at a daily basis in our institutes. So from my institute, which I studied, so if you look at the pattern shift in our institute,
In 2021, we are doing very little amount of MIGS, whereas in 2020 data, maximum number of surgeries, MIGS is taking a big chunk. And if you look at the MIGS being done, it's pictures of 2024 and how the mix numbers and gag numbers have going so high, and we are like all the MIGS are taking a bigger scene. So with this in mind, we start with the first MIGS, that is the Tanito microcephalectomy. So what is basically it is a it's like a silky hook kind of device, and there are two of it. One is for the right hand side, and other is for the left hand side. So after completion of a picomultiplication, here is the device, and the left-handed hook is the left side of the angle. The right hand side is for the right side of the angle. So after completion of a picomultiplication, you can see how beautifully it gives the particular network. And then you change the device, the other side one. And this, of course, the patient is having a very nice, beautiful open angle, a very nice cervical network, and well visible angles, well visible anatomy. But even for a case like a very bad, like a primary amyloidosis glaucoma, with excessive synesthesia, we can try this next also. So after completion of a good picomultiplication and putting good viscoelastic, the main barrier in doing mix in any glaucoma in primary amyloidosis patients is the synesthesia. So we go ahead with doing the scientific analysis, as we discussed it with Amardeep Madam this afternoon also. So even after doing the scientific analysis, any case can be conquered and can be treated with mix like we do for the PAD case. So like here also, the after doing the scientific analysis, the cervical network is very visible. You can see the cervical network, and then you can just go ahead and do the external trabeculotomy over there in the micro. So here it is, this is very nicely. So even for a very horrible cases and very difficult and very challenging cases like photoblastoma with presenting with like very difficult to cataract, of course, doing a trabeculectomy in such cases is very difficult. So of course, you can go ahead with doing picomultiplication, followed by this microlog, this kind of micro can come as a restaurant for this patient, certain patient. So here you can see once the trabecular network is well visible, you can go ahead with the MIS procedure. So even for a nano-ophthalmos case, I just show the first. This is for the pre-op patient, pre-op photo of the patient. Where you can see all the angles were showing, shallow, lens was swollen, and after performing, we went ahead with performing a picomultiplication. Followed by a trabeculectomy. So if you perform a trabeculectomy in such cases, we definitely have high chances of having a post-operative glaucoma and other related complications. So this was the pre-op ASOCT case of this patient, and post-operative you can see how beautifully the angles are open and the chamber is well formed. So this was the first study done by I hope sir joins online. We can discuss the study. This was the first study ever done of Tanito micro in which they compared Tanito outcome with plain picomultiplication. And here you can see there is a very significant drop in the pressure when you compare it with the plain pico. So one thing which we have is noticeable by end of 12 months, the pressure in the Tanito arm is 12.645, and in the plain pico the pressures were initially low, but after 12 months, after 1 year, they were rising. So of course, Tanito is great, sir. And this is a transplant trial that initially, which they converted, they compared the Tanito outcomes with the trabeculum. So Tanito had good 74.2% outcome. So this is the inventor, Tanito, then Dr. Masaki Tanito, sir, and our mentor, Dr. Deven Mehta, sir. I hope to join. He can tell more details about this site. So I got the opportunity to learn from my guru, who was a close relationship with Dr. Masaki Tanito. Another place which is very widely used, even discussing mathematics is also using almost everybody in their using this is the Kahoot dual gate. So I just discuss, I will not go in much details of it. And so even if a PhD case can be conquered and can be easily managed with a Tanito micro also. After doing a good scientific analysis and having a good view of the trabecular network, we can go ahead with performance of our trabeculotomy using a Kahoot dual gate. We see how beautifully the proprietary thing of this Kahoot blade. They are beautiful blades. And a very nice story I was discussing, Madam also about it today afternoon. the dual link was, as an existential thing was designed. Like scientists were searching something which can take out the sample of the cellular network. So it was developed a sampling device, but luckily they saw how beautifully the pressures are getting, and you can see in this video how beautifully the actual and the character channels and network streams are getting changed, and it proves our that you can look at how beautiful the branching is there. So this proves how successful this surgery has become. So this is the ASOP of the push of the patient and the pressure drop is the reduction of energy at the end of 18 months. And here is the nasal angle depth you can see very comfortably in this picture. So another challenging case is the silicone glaucoma. We have published this case in our we have published this case in silicone glaucoma was managed along with these variables here. So after completion of the clinical cataract surgery, we went ahead and performed a considerable goniotomy in this case. So, of course, KTB has a cost associated with it. So, we have a more much economical option available with it, that is band. That is band ab internal needle connectivity. So, it is what we do is, after completion of the reconstruction and all, we go ahead with bending the needle in the reverse clockwise. So, even this can also behave like a KTB. But of course, the outcome will not be that great with as compared to a trading field. So you can see how beautifully we have just got the reduction of frequency network and just excite it. It can behave as it is, like a cake. So our issue is comparative study comparing the micro terminology versus the bent to. And we found that it was a randomized controlled trial run in which 35 patients came to the end of 1 year, and we had a very nice consistent IFA drop in both the arms. And we had a very nice success rate when we using a very stringent of this IFA criteria. So another one is the Espelard goniotomy. This is recently been coming up in India. So what is the proprietary and what is the beautiful thing of this? They have two foot plates. This is the foot plate we use, and it has a very non-traumatic, atraumatic fit which glides inside the trabecular network. Again, in this photo, you can see this is a very atraumatic blunt slide and take a slide. That's what we call Espelard ductal space slider, because it slides, it makes the space and gives the trabecular network in a very atraumatic method. So here you see the video how it is going like this. And we can go on the other side also. So we are achieving around 60 to 120 degrees. If proper tilt and everything will be achieved. So there is another video for the same. It is the typical method of the very beautiful thing. So you can see how it is sliding. So we are doing the study comparing the outcomes of band and we compare it with the Espelard goniotomy, and we find consistently both the had a significantly good reduction at the end of 6 months. And success rate was also really good, like roughly around 85.7% complete success and in Espelard group, and in band group it was 81%. So coming on the last mind is GAT. So GAT is basically designed by our global sir, Dr. and Dr. Pelman sir, and I was very lucky enough that they went to Maheshwari sir because he taught me how to do CAT. And you can see this, I hope the video is little small, but this is a very seriously advanced glaucoma case, and this is one of my initial case which sir was teaching me. So here you can see PI how even the PI in the CAT and the pressure was still high, and we did a GAT in this case. So here is my initial learning time when sir was teaching me doing these cases. So here I am here and sir is sitting and looking at my one case. So, and this was the first video we published in IGO, and it is well available on YouTube, and like you can log in and check the steps of the surgery. And here I just move on to the basic steps. So first, after visualization, first step in a CAT is blunting of the fibropolyp to the step. Once it is bent up, then we go ahead to doing a 2 to 1 to 2 nasal goniotomy has to be done. So you can see we are doing 1 to 2 mm or 2 kHz of nasal goniotomy. Then we fill in the vesicle, and when we have to use a maximum forces to thread that blunted tip of pyrophilic feature into the stents canal. And once you have to give 10 to 20 strokes for it, and when you see the dystrophic, you have to just grasp it and then complete the specific episiotomy. So even for a this, we submitted our data in ISO. It was published in 2023. In PVH glaucoma, we had a very good success rate compared, very good success rate. Same data we had same we had studied for that in junior open glaucoma, which was published in 2024, which also had a very nice success rate in that being done in European open glaucoma. So another video just recently came last month only. This was again published by Sir and me. And we discussed this is available on YouTube also, in which we have done that in more challenging type of glaucoma scenarios, taking a step ahead with it. And this is the link for the video. And you can search it on the ISO videos channel. So even for a gap in PhD cases, you can do a cynical analysis, expose the clavicular network, and you can once the clavicular network and is there, you can just go ahead and not be and you blunt the tip and insert it inside the clavicular network. Now it goes in the Schenck canal. After 10 to 20 strokes, you can see the bleeding is coming, and just we have to grasp and just complete a 360 episiotomy. So here you can see ASOCT is a very good agent. Here you can see based on all PCT, so proof of it is you can see a goniotomy, the goniotomy have seen in both 180 degrees, over here also and over here also. Even for the challenging cases like patients with, so in that purification also, once with goniotomy, you can do a nasal goniotomy, the angles are very visible, you have done a good goniosyncytiasis, you can do a gap very successfully in the patient. And it's a really a very happy situation, happy thing when the two IPM answer will be discussing about it. Once you see that they coming from the opposite and you are very happy, and like it's the happiest moment of the OT that day. Once you see that is coming. So even for a even very scary looking shiny case, you can see a very scary looking shiny case. In this also we can do a very nice shiny to like this. And once cynical access is done, that hidden clavicular measure which was hiding behind it is very visible. You go ahead and doing a goniotomy, exposing the clavicular measure, exposing the Schenck canal, bring it down, and then just go ahead and doing the gap procedure. So if you look at our institute data like Vicer and we are having around 85 to 81%, 85% of the complete. Giving us two criteria for 89%, 81%, and we include around 90 patients in our data. It has been published, it's under consideration for publication. And even we have reported a case of a reversal of cupping in a patient or young patient, 32-year female, which after that, there was, after a 6-month duration, there was a reversal of cupping seen. Even for secondary angle closure, one case I showed was a coloboma in a Calico and done. There is another case in which that has been done, a coloboma patient. And you can see in this case, the rate of first equation of GAT, after finishing of the GAT procedure, he went ahead with doing the sacral emulsification for this patient. So even for a patient like silicone oil induced glaucoma, here you can see after removing the silicone oil, you can go ahead with performing a GAT in this case. And in this, we have a very good achieved IIT, like from 34 mm energy, it went to 20 mm energy without single agent. And even for this, I remove, even for a post-failed surgery, like we are having many patients who are having failed glaucoma surgery. So here is a video of GAT being done for a patient who has a failed trabeculectomy. And we go ahead with performing a GAT in this case also. Even for some patients like very cystic breast, in this patient, every medical manager will also agree to me that in such cases, doing a repeat swab is very, like because particular level is mistake. And conjunctiva is not that heavy from a tube also. So in such cases, analysis like that can help us in achieving a pressure control technique. And here you can see, the only thing is we have to be very careful in this because the suture might get lost in the punch area, the side area. And here's a very beautiful video. This patient, I would like to discuss this patient. This patient had two trap done, one side left bleeding done, and a tube being placed also. Here you can see the tube is also being placed here. Here is the CCTV view of the ACS. You can see the tube is also coming. And the beautiful thing is you can see both nasal and temporal. You can see the very clefts of the gap being done. And the patient was very nice, I will remember. But everything but bright is not everything. Like we say, everything inside is not good. So MITS is also associated with many complications like microedema, macroedema, blood loss. And if you are not careful, you can even have a iodine, especially if you are going very enthusiastically and doing an case, and you can even land up with cyclodialysis. There's another case report which I submitted, which patient presented after 2 months of a successful gap the blood staining, electronic color staining of the posterior capsule, which was successfully managed with gap caps. But yes, we can have a good document. So this is my team with Dr. Deven sir, Dr. Madhuri madam, Dr. Mutha madam, and we have more than 20 plus MITS research. Some of them are published, some of them are ongoing. This is my mentors, my gurus from Dr. Arvind Hospital, Dr. Venkatesh sir, Dr. RK sir, Dr. Mohini sir, and Dr. Matt sir. And this is my Dr. team there. And I'm very happy to go back to my hometown, Dehradun, and very excited to see so much MITS work already going on here. And I'm really happy that sir has given me the opportunity to talk on this. And I just ask, thank you all for the patience listening. So I request sir, if please join online to speak few words.
Yeah, so first of all, good evening, Gaurav sir and respected seniors. I think it's a very nice presentation, Shivam, and really it's a great honor to listen you. What you learn from here, you practicing there is very nice. And apart from coming to MITS, really MITS is really need of the time because in Indian scenario, any scenario right now, compliance is the biggest concern. So really even put zero come follow up. And somehow be the MITS is the new with us. Right now we have multiple choice. You speak MITS can then only the Western countries. Right now we have the different kind of MITS as the system told. Like we can start from this band like bag, then we can do the micro hook, then we do the ADB. So these are the some costs state states apart and might anybody the body stopping meticulous workup. So what we we have dose of 120 days, we do the body the same thing to the body stopping while doing the treatment. Then that what do you see? It's not that always for the court case. The next either you can do KDB, you can start or Tanito, available Tanito. Then you start.
The voice breaking. On the phone. Hello. Yes.
Yeah. Talking about the 2020 rules. So the 20 case you have to do just the body story, then 20 case, next 20 case, just you touch the total muscle, and first 20 cases you record. You can start getting either pain, your body story, or you can start with the KDD, and slowly when you perfected the ECMIS, you can go for that again. And some of the video Sivan has showed that limit yourself to the first primary performance, Because once you master in primary reference glaucoma, then venture into the medical soldier and some difficult case scenario. Uh, that's all from my side, and I am very grateful for giving this opportunity. All the best, Shivam, and thank you very much for the sir.
Thank you, So we have one more presentation by Dr. Jay on eyesight. So please pay for the presentation, sir. It will be by the end of the webinar. I'll ask you the message in start. I request Madam to start with the question.
First of all, welcome Dr. Shiva, welcome to Dehradun, back to your hometown. And I hope you are enjoying your initial day in the industry. It's a very good place. And hope that's all it was beautiful. An extensive, elaborate presentation has been exhaustive and included so many things. And you emphasize that we is really working in angle closure glaucoma. It gave us really good results in angle closure. When we remove the leaflets, then we go for PN and we do some management. If there are sanitation, we do the good sanitization and we but one thing I would like to ask you, Shiva, these PM-based procedures, they are actually for what is the amount of pressure drop that they call?
Yes, ma'am, very nice, ma'am, I think so, the pressure drops are good, ma'am, around, we can technically 30 to 40% pressure drop. And, very big topic which is being discussed now is the degree of angle needed. Like, if we compare, like what we are seeing, the degree of angle needed also matters. Like what our institute is showing, but some studies are saying that no, you are like a 60 or you are 120, doesn't matter. But we are doing a study which is showing 180-degree gap versus 50-degree gap. And of course, some patients, especially a PVG case, what Madam was also saying, the primary open eye glaucoma cases, I think so, we should do a 360 gap, 360 as compared to a primary annual project glaucoma case. In annual project glaucoma case, the sanity is there. So once you move the sanity, so even if a nasal biopsy is done, because that is a very new area for the field to show. But in primary open annual glaucoma, already the collected channels and fibroids, there's a collapse, the very nice actually very nice actually of IKMS slide is there, which just could collapse the clavicular. So where it could collapse collected channels, it is coming in the clavicular. So PA is already a little dicey area. In PAC, definitely a 360 is much better. But in a PACG, if you can achieve a good sanity analysis and you can do a nasal sanity or nasal band, it works really nice because that area was never used for like 30, 40 years because of the sanity or whatever, it was totally closed. So of course, it is a very nice, yes, so that titration thing with the big game will come. I think so I have answered it in minutes.
And what about POD, advanced POD? That really working.
I still believe what works best, one certain hand would be the preferred. Because I was also very scared and I was like, when I was a fellow, I was very like, angry you can say, when I used to see a patient with advanced glaucoma and I was to advise that, but there is another faculty engineer to convert it to that. So I was like, if I doing this, people are definitely in my hands and get a less than 10 pesos for him. But sir was like, no. And I was like, no. But once I started doing about this, when I went to doing that or thank you for that, then I feel like, okay, if even for advanced glaucoma, let's give a trial of medicine. If it fails, let's have a medical method here. That is, and one thing for sure that even sir will also agree to it, that bipod and snowboard is not a, like, it's still a, I don't think it's there. So anything which works in that for surgeon is the thing. What I believe. But your education will also agree to.
Yeah, I agree with it. Good. Compliment for my side for wonderful presentation. Because the videos are great and clear. And you already answered my question today. I wanted to ask whether that first or a KP or any of the partial or not. You already answered depending on the KO, AD or the in advanced diploma, I still have the reservation. If you look at this particular advantage that you are also because patients are not special from the medication. Right, so the president that are for the advanced diploma, they are already fighting. So what are the results that you are getting here?
Sir, advanced glaucoma paper is doing the 100%. And of course, it was giving equivalent good result as, but it was proper head-to-head RCT is being done now, like very unethical thing to do, but of course, like you can have a retrospective or a prospective study, which will compare the output, the advanced glaucoma track with the advanced glaucoma gap. Some of the patients in juvenile glaucoma which I was taking, they were very advanced patients. So in that case, we had a very nice outcome. That specifically for advanced glaucoma, papers are there and it's showing good outcome. And of course, if I'm treating an advanced glaucoma, I definitely go for 360 MIGS as compared to a limited MIGS, like a band or a tent. But again, man, I'll be again things like we discussed over that case also. Like every patient management is totally different. What like they're managing from different for different patients. And what works best in your hand. Like I know I can give this patient my best in this type of surgery. I do that. I don't see it. So that area is still, like what to do for what fix.
Like, what is the silicone oil will go and block the collective channel eventually, and it need a second surgery later.
Definitely.
So why not go the first surgery, like, and we should not have go to procedure.
Definitely, you are correct, ma'am. And this what I conceptualize, and of course, we have a patient with 36 months follow, but let's leave that patient alone. What my opinion, what I saw and what the patient I was seeing there. So you already being on a glaucoma patient, the conjunctival is not that good because they are undergone two surgeries. First was for the vitreous surgery, whatever it was. Second was the SOR. So now the patient is already silicone is there, engulfed inside the collective channel. Of course, the collective channels are there and that micro bubbles are there. So of course, what madam is saying is totally correct. For that patient, I might just do a temporary solution. Like for 2 to 3 years, you can take out number of anti-glaucoma medication, whatever you or she was using. And then you can go ahead when the conjunctiva is healthy enough to do a trabeculectomy or a tube, and definitely prefer a non-valve device for a silicone like. And so depending on how healthy my conjunctiva is, I think that the decision will be on how the healthy the conjunctiva is. So I think the primary decision will be that. Anyway, thanks a lot. And, the thing is that, also, are there any doctors that you can take them in to work out for taking of these? So, second question, can you always be for patient does want to develop how effective is the damage? So first of all, what I was, because 21 is the time when I joined my fellowship, and luckily that was the time when MIS came. So I was there in 2004, 2022 I was there, 4 years, whatever patients were coming, and they were doing good enough. One thing for sure, some easy the like connecting is like band and the beginning connecting that therapeutic network can collapse and they can lead to fibrosis. Even Madam was saying that some patients we have the mostly evidence also. But outside India, we have the models of 4 to 5 years data with that being very nicely done. So yes, of course, this is a very medicine and post that or post MIT, especially CAD, excisional goniometry, would fail these surgeries. Any trabeculectomy, I have not found from along the data, any studies of that. Post Einstein failure, post like Madam was saying about what is that, expression, post expression, we also have one case of post expression, patient don't get. So that is there, but not cancer here. Thank you.
So when training started in 1980, when we were operating, that was practical. I used to go to the conferences, various conferences, just to see any case. For many years, there was hardly any case. So drugs to control, our aims to control the glaucoma, scientifically or medically, or your solicitation and ICF, if you can come close to the authority by doing internal management, that is great. Very close to the
Thank you, sir. And the report continuation of what sir said. So these things are not new. Otto Warburg described these things long back, and we were doing all these things. It was just device-based MITs were predominating the thing. So they were not able to be introduced in Indian market. Like India, like our acceptance was not there. But thanks to growers, and literally they came up with gap, they came up with Dr. Tarito sir, and they came up with these educational modalities, and they have been very nice outcome, and they are getting very, as Sumant will also agree to it. So it has given a very nice option to us. Like technically, you know, I go to surgery, so it's still our, I also go for PhD, but it's given a nice option to us. And so Madam can also agree to it.
Only agree, I mean, statistically, one has to go, no. You cannot say you are a glaucoma surgeon and you don't do that, so we only do make surgeon, that. I mean, removing the scale is there for some reason, yeah, removing it, it's okay, but you, there is always a debate. So things will come and things will, time will come to know with age, I mean, this is very, there are some things come and then they go away because we kind of don't know they were facing some problem. So right now we are studying, we only have in my hospital like 2 years data, 2.5 years data, but patients, not all are good, but most of them are good, 70% are good. So it's a good choice, we have another option for glaucoma patients. And if you're doing a cataract surgery or cataract surgery, you can combine them. Thank you.
Thank you. And now we go on to the second talk, by Dr. Vaibhav. He will be the retina consultant, vitreoretinal surgeon at our setup and Vichy. And I would request Dr. Estikal, please join us on the panel, and Dr. Anamrita, you can also join us. I will invite Dr. Sandeep to
Good evening, everyone. So I'll quickly take you through the cases. So I'll be presenting a couple of intraocular cystic cirrhosis. So our first case is an 11-year-old female which presented to the OPD with chief complaint of diminution of vision in right eye. So the best corrected visual acuity was 1/60. 1/60 in the best corrected visual acuity was 1/60 in the right eye, and on critical examination we could see 1+80 cells and 2+width cells. So I'll quickly take you through the video, incorporated all the images, the video only. So here we can see on fundus examination, we could see some vitritis present, and there is large subretinal yellowish mark in the intranasal region and extensive subretinal and epiretinal fibrosis in the inferior part of the retina, and some adjoining chororetinitis area. So we went ahead with the OCT scan. So OCT revealed SRF and RD. We went ahead with the V-scan ultrasonography. So on this, we saw cystic lesion with a hyperechoic inner structure, which is also known as dot sign, which is very characteristic of light cystic circle, and this is the scoring. So we had the diagnosis, and it's a subretinal cystic circle. We went ahead with surgery. So PVD was carefully induced as the vitreous was residently attached to the underlying retina and the fibrous tissue above the necrotic retina. and there was a lot of fibrous tissue overlying which was peeled meticulously and very carefully. I quickly take you to the case. So at this juncture, in from we saw, initially when we saw that the case presented to us, the cystic ulcer was subretinal, but in from we noticed that the cystic ulcer is communicating one, partly it is in the vitreous and partly subretinal. It is described by R. Kumar et al. In 1989. So very carefully we delivered the cystic ulcer in the vitreous cavity with the help of an extrusion and a soft tip. And taking care so that the cyst doesn't lie within the vitreous. Otherwise, all the toxins will be released in the vitreous and there will be massive inflammation. This particular step is very carefully done. And now you can see that it's being delivered in the vitreous. And here we can see when we put endolite over the cystic ulcer, there are undulating movements. So basically, we did a lysis with the help of a cutter and removed the cyst, taking care that there is no toxin released in the vit cavity. FX was done, endolaser was done extensively. Siliconized tamponade was given. So this is the picture. First post-operative day. So retinal looks deficient has been removed and there is not much inflammation. Same can confirm with the OCT. 3 months post primary surgery, patient developed some ERM. So we decided to undertake the patient for SOR with ERM and ILM feeding with a gas tamponade. So after staining the ILM with BBG, we meticulously peel the ERM ILM complex. Which can be converted on intra OCT. So where exchange was done, and this is the picture after all the gas had absorbed and patient improved to 680. So second case, which is the better case, or we can say this is the case which justifies the title of this topic. So 23-year-old male presented to the OPD with a chief complaint of blurring of vision in left eye in 1 month. The patient had gone to multiple centers and multiple diagnoses were already being made. There was one typical past history of fog consumption. So on examination, the best corrected visual acuity was 636 part. There was some posterior subcapsular cataract with vitrectomy. So here we can see a round well circumscribed yellowish lesion present in the inferior mid cavity with overlying blood vessels. So at this point, we had some retinal mass in our mind, and we went ahead with the OCT, which showed CME neurosensory detachment. Again, what changed the diagnosis was the ultrasound. So here again we can see a cystic lesion with hyperechoic inner structure, which is again very specific for cystic cirrhosis. So we decided to go in and operate, and the diagnosis was confirmed with NCCT head, where we can see some calcified granulomas in the occipital and temporal region. So diagnosis was made, we were ready for the surgery, and we went ahead with the surgery. So IPV was already there. We did the vitrectomy. And after completing the vitrectomy, as you can see, this is the protruding part. We thought that this is the scolex part. The scolex is protruding. So we thought of making a retinotomy at that point and delivering it into the vit cavity. So we did a dietary assisted retinotomy. But we could not create a retinotomy over there. So we decided to put it in the upper part. We did diagonally, we tried with the extrusion tip, we tried with a cutter, we tried with a forceps, and we tried to peel the very fibrous overlying structure. And we could manage to peel it by force though. But at this point, as you can see, when we peel the outer cover, there is this thing inside which is again vascular. So at this very point of time, we were confused. What we saw on the D scan, are we really dealing with that particular thing or is it something else? Is it a vascular tumor? And if we go and try to put it a cutter over a vascular tumor, then we are creating problem for ourselves and for the patient. So at that moment, with that thought, we thought of abandoning the case and we thought of taking it up in second setting. Because we need histopathology support for such a tumor. So this is the picture next day. So here you can see these flaps what we have removed, and there was this mass, which is again it's vascular, not very typical of cystic circle. The patient was given post-op medication. The patient was referred to PGI. So this is the image taken at PGI Chandigarh. So they went ahead and did a FFA, white field FFA. And as we can see that there is vascular tissue all along that mass what we thought earlier as cystic sarcosis. It's all vascular and it's not typical for cystic sarcosis to have such great vascularity. And at this point, we were thinking that it might be a vascular tumor. But again, the D-scan findings were so characteristic of cystic sarcosis that we cannot just let go that diagnosis. So we went ahead with and did an MRI to confirm. An MRI again showed that there is a hyperintense nodule in the posterior compartment along inferior wall, which is suggestive of cystic sarcosis. We did ultrasound, was repeated, and again it's very typical of cystic sarcosis. You can see the dot sign, you can see a hyperechoic inner structure. But one thing which amazed us was a thick coat overlying that cystic circle. So at this point, I would like to come to two diagnoses. One is retinal vasoproliferative tumor and another is ocular cystic sarcosis. We come to them one by one. So first we come to retinal vasoproliferative tumor. So a retinal vasoproliferative tumor are rare, usually unilateral, and they're benign retinal vascular tumor. Mainly present in any age, but usually present in the third and fourth decades of life. So they can be one or more globular vascular retinal mass lesions with or without clear vessels, with retinal telangiectasia, and color may vary from faded red to intense pink to a more serrate dirty yellow. It's usually predominantly present in the pituitary and infratemporal location. It can present in localized diffuse or remote macular infra and subretinal exudate with macular edema or epiretinal membrane. So basically, what's the pathophysiology? So in this, the initial retinal ischemia and inflammation leads to reactive proliferation of blood vessels, which again leads to unchecked proliferation in a loose glial matrix organizes itself into a vascular mass. And over time, reactive glial predominate the vascular component, and that's why it has a yellow-white color. For histopathology, glial cells are interlaced in a fine capillary network with the dilated, hyalinized, partially occluded blood vessels with exudate, macrophages, and foreign body characters. So coming on to the classification, it's primarily in 70 to 78% of cases is idiopathic and secondary It can be because of retinitis pigmentosa, Post disease, ROP, familial exudative retinopathy, retinal vasculitis, intermediate uveitis, choroiditis, oculoplasmosis, chronic retinal detachment of endocrinology, prior photocoagulation or cryotherapy or VR surgery, and neurofibromatosis type 1. Till date, I have searched literature, but there is no direct correlation between vasoproliferative tumor and ocular cysticercosis. So there is a proper staging for retinal vasoproliferative tumor from 1 to 5, and every stage has been bifurcated to 1A and 1B. Coming on to the management of vasoproliferative tumor, so lesion less than 3 mm in diameter and thickness with no overlying SRF can be treated with laser photocoagulation or transcranial thermotherapy. Lesion less than 6 mm in diameter and less than 3 mm in thickness with or without SRF can be treated with cryotherapy. Lesions more than 3 mm in thickness with or without subretinal fluid can be treated with plaque brachytherapy. Patients with macular edema and predominant exudation can be treated with intravitreal triamcinolone. Patients with macular edema, exudation and predominant vascularity of the lesion can be treated with intravitreal anti-lesion. And fractional artery unresolving viscous retinal membrane can be managed with a DRC. So we have some articles for retinal vasoproliferative tumor, where they all have given 4 cases where they have managed all the 4 cases either with the VR surgery or with PDT and intravitreal bevacizumab. So here are 2 cases which have resolved very well after PDT and intravitreal bevacizumab. Coming on to cysticercosis, basically we all know about cysticercosis, that it's basically a larvae tinea sodium, and what are the stages it goes through? So it's a live or vesicular cyst in which living cyst with a well-defined spolate. It causes minimal or no inflammation in the tissue. Then there is second a choroidal vesicular stage, and now begins to die. The cyst wall becomes leaky, it releases toxin and causes varying degrees of inflammation. And this third stage where it is calcified nodular stage. Eventually the larva die and are either totally absorbed or calcified. When cysticercosis stop growing and begin to die, the vesicle wall becomes thickened, calcified, and shows sign of damage. These changes indicate the transition of intraocular lesion into the degeneration and dead stage. The scolex tissue is crucial in the cysticercosis development. As the scolex develops into an adult, it evacuates out of the respiratory wall, sucking disc and hooklets achieve maturity and blood ball helps the other. After that, the scolex structure disappears and undergo calcification and fibrosis. So there are 30 case reports in which this past nephrectomy has been done, and in vivo cystitis for intraocular cysticercosis, in which one of the cases the cyst was dead and calcified and could not be removed. There is another case report in which a giant subretinal migration of cysticercosis with extensive epiretinal membrane and subretinal fibrosis was reported, in which there was extensive epiretinal fibrovascular membrane and subretinal fibrosis in a case of dead cysticercosis. So at this point, we had 2 diagnoses. It cannot be just a cysticercosis because there were multiple layers of vascular tissue around it. So we hypothesized that maybe after the cysticercosis was dying and it became dead, there was inflammation around, which led to the development of vasoproliferative tumor. So it's a combination of cysticercosis and a vasoproliferative tumor. And it's still a hypothesis because we don't have any histopathological evidence to prove it. So I open this discussion to the panel and to everybody here for their valuable insights for this case.
I want to ask, what your vision of space and how much information there is.
Which was first case or in the second case?
And if there was this, has been that.
Okay, okay. So the bill was 636 part, and the patient presented to us, and there were 2 to 3 with there. And as you can see, I'll show you the photograph. There's not much of vitritis because there's not much of vit haze in the initial photograph. So this is the pre-op first image. The patient had 2 to 3 plus ulcers, but not very severe inflammation. Not very severe. So, as in the case of dying or dead twisty surface, we expect that the inflammation would be much more. But in this case, the inflammation was not that much. I think OCT images. No. Central, but not in the peripheral, not through the lesion or through the.
That's the question, Bayo. The thing is, what we are doing for us is that it looks like this is supposed to you as far as the base and all. So it was a kind of a very difficult situation in the OT. I was operating, I was on. What we could see is that the amount of repair is not that significant, considering such kind of a stage. When we did the B scan, we operatively, there is no doubt that we are 100% sure it was a surface only. But whenever there's a live C scan, with the Android position that what you showed in the first case, you start moving the your scan, but there was no movement like that. But opening up the cyst was the biggest challenge. But we tried for, say, for around 45 minutes to 1 hour. There we tried to dissect it out. But there's a little bit of weight, not a very significant weight, but a lot of muscularity was seen during the relation. So the case was never bad. Most of what I meant is that the CNA part significantly resolved on its own. Yes, the CNA, and when we last saw the case, and it was actually the COVID that was it was just an open cyst without any inflammation even also. So although the patient is handled with an oil otherwise and topical steroids, but still the diagnosis that as well as say between cystic surface or masses in mesoproliferative tumor. But again, we thought that some other events include that it can be like cystic surface has led to a PPG or mesoproliferative tumor because any inflammation, anything can lead to. But I asked you to search for an existing search, but
I have done the negative, there's no paper, no case report, still there's no clinical correlation or the direct correlation between vasopressor with the tumor and cystic surface. No clinical correlation.
But what the etiology says that even any infection in the postal segment can be treated at the blood or whatever.
Inflammation or infection.
Yes. And as you showed with the B scan, the later B scan, where there's it's significantly deeper.
Thick.
Significantly deeper. So that itself is, goes towards, yeah, this is not very usual, the kind of calcified skull exploded within the big system access you want. So the pattern you take is very much about finding cases of from the past and so how this was tested, and you can see the videos also is that when we use the PVD and the region of the vitreous and the membrane that form in a cystic circle which is communicating with the vitreous cavity is much more. Of course, it is lesser in subretinal one because as yet this is not inside the vitreous cavity. So this was if at all the subretinal cystic circle. So we don't expect so much vitreous inflammation as in the communicating or the intravitreal cystic circle. But still the vitritis was not so significant. The membranes were not so significant. Vitritis was significant, but the membranes were not so. So that was how this was different. And this last picture actually is from the by radiology. It's by a transducer which is not like RT scan because I was totally shocked. So when I said that after the surgery, I immediately called the Ramanjeet and PJ and asked him what we are dealing with. And from the immediate he said this has to be a cystic surgery. So I said, okay, well, I'm testing to you because I tried my best and in the end, if you see towards the video, the last part I have insinuated my instrument within the space between the lesion and the globular, kind of swelling, the subretinal state. And I could see the gritty sensation of that wall. Maybe it was a calcified wall. So what probably we have intervened at a time when the cyst is already dead and it is getting calcified and in the process is
there is a lot of inflammation and vascularity, which is kind of moving towards the vasoproliferative tumor. So we've got the lesion in a state of evolution between a dead cyst surface and maybe a vasoproliferative tumor, although it is never reported directly after a dead cyst surface. It's mostly calcified, never reported as a VPC. But this is what we are kind of hypothesizing. But according to the radiologist also, this could be nothing else, and even on the MRI, it could be nothing else than, so the reporting from the MRI was done at PTI, reporting has been not been done as yet. But most likely it's going to, because we sent the images to another radiologist, not in PTI, and they kind of reported it as a, so that is why we wanted to share this case, that it's a rare case which looks like a subretinal test cyst surface, and this is getting calcified with so many layers around it on the brain scan. This is very unusual, and also then the industry diet usually we expect a lot of inflammation. I goes into I will have hypopion. It will have severe inflammation, and if you don't treat it, it can even go inside. It's so bad. It's like a permanent, end of kind of situation. But we never came across that kind of situation in India. So that is why this case is kind of unique. That's what I wanted to say.
Doctor. Vision and surgery also. The cortical is very common in the blood, and I have seen lot of cases of projectile issues of course as well as that in the AC also. Sometimes the what I have seen in my 2019 in the AC the positive was there in the first day that was going the first coming out and going back, coming out I face just like that. I have videos also. I will see I saw this the paper on this because this is the excellent presentation and I like it very much because I am dealing also with the purpose. I can discuss that with you if you don't mind. The last case, the 14-year-old child comes to us. They have examined the baby from the position like it is 16 elevation. And it's little bit like this. We have done the ocular movement test. All the movements are restricted in the superior. Natural elevation, natural liver elevation, and superior. All the movement was restricted in the arcade, but down this movement was perfectly alright. And that side was perfectly alright. And the pupillary reaction, no RABD at all. And we thought to what happened, but एक साल से करता है, repeated call का इस्तीफा का सारे ओके देखते हैं, पर बाकी क्या हो सकता है जिसमें केवल एलिवेशन दिखाते हैं और बाकी I thought something in the inferior aspect, but कुछ भी है तो inferior aspect में because patient wants to हमने कुछ तो करना होगा, and then we did the CT scan. And one thing I asked the head about, do you feel any pain on the ocular movement? He said, yes, I have the pain and the superior movement, any desktop elevation, below and superior. I said, okay. And second question I asked him, diplopia, he has done the diplopia charting. He has diplopia in all the cases, except the desktop reflection. In all the cases. Third thing I asked him, when you feel more difficulty in the office chair or down stairs? That I feel more difficulty in office chair. ठीक है? तीन सवाल आ गए हमारे पास कि हमने कहा क्या कर सकते हैं CT scan करना था. Anyhow we have done. When the CT report came, what we have observed in the inferior aspect, there is a big mass, looking like a big mass. Then I said, no, one more thing, we have to do the MRI. We have done the MRI. Then in the MRI, आपको MRI देखने का ऐसा लगेगा जैसे कि optic nerve glioma type. The picture was just looking like a optic nerve glioma. Then one thing I observed, one encapsulated cyst, and in the middle of that, some calcification I have seen. I have confirmed, yes, it is a cystic cyst. Then what I did, I said, don't worry, आप ठीक हो जाओगे. Then we have started. I am just 4 days practice. Then I have done all the blood investigation. I want to see whether you see or not. Then that investigator was very normal, very no years, no, yeah, anything. Then I said, he was not vegetarian, and then I started according to the body weight, salt. Cold out salt, 3 days, 4 days, I given me salt, then I started the dose according to the body weight, whatever mentioned. And then I asked him, second day, I asked him, how you are doing, third day. He said, little bit, basically ocular cysticercosis myositis. Because of that, and because of that, and one the most important thing what I have observed, when my PG taken the I get done the gap, that time his one eye pressure was 38. It was coming at 38. His pupillary ejection perfectly normal. The water finding perfectly normal. No stopping, nothing like a glucometer. But pressure was normal. For the more or less here. And I thought, what? Then I had asked my PG, do the intraocular pressure in upgauge and downgrade, both the days. My PG then gave that in upgauge, then the pressure coming on that time pressure was 38 and in the downgrade pressure was 80. Okay, I said, this is the confirm. Yes, it is because of ambulance is because it is involving the interior actors and that the patient asked in our case, that time pressure was down, high and penetration looking down, that time pressure was low. So down gauge was the 18 upgauge, when I said stop all in the anti-glaucoma drug, I initially I started I said no, stop it. No need of any medication like anti-glaucoma. It's just I have started in full dose steroids. And 3 days, after 3 days, I have started the albendazole according to the body weight. And let's see what happens, but third and fourth day when he came back, he said, no, I'm good and now my pain is little bit less. I'm not feeling pain in ocular movement, but it will take time, at least 1 month, I think so. And it was interesting when I see the ocular because it's really interesting, and I think if CT scan play a very important role in this. If it can happen anywhere. I think it is very important. And I have taken the procedures, physical courses in the way anywhere. I have to rule out and finding everything. But all the findings were normal, but the positive things I did seeing, but initially it was just maybe Brown syndrome and LPS complex, something like this. But I don't think process नहीं important जेनाटोसिस नहीं था people जिसको normal था बस ये लगता था कुछ है तो interior actors में तो we were very much excited for that case, but your presentation is very interesting and very good. Thank you.
Thank you so much for this, now we have 10 minutes to finish the meeting because we have we have two case presentations, one from Jay and one from Mr. Swami. So Jay, you have 5 minutes, you have 5 minutes. So okay. There you go. I invite Gita in office with the please come. So, we'll start then.
Okay, good evening and welcome everyone. Today I am going to present the third video and discussion about the iStent, a tiny device giving a transformative result. Why iStent? Earlier concept was to put the AGM if the patient is resistant to it or in need of any invasive surgical arise. Now the concept has changed to enable a review And with minimal individual intervention, we can reduce drop dependency, also reduce age-related side effects, and make the drop rate more optimized and more way. So that is minimal invasive glucose surgery. A class of procedure enabling early physical intervention in the treatment of open angle glaucoma, and it avoids the risk of invasive filtration procedure. I said the first FDA approved MIGS device. What mechanism? It's designed to improve the FPS outflow through the natural physiological pathway, and it creates a bypass to the trabecular meshwork to slab channel. In this image, you can see that on the left hand side is the obstructed or dysfunctional trabecular meshwork in the patient of glaucoma, and on the right hand side you can see that Einstein device which is bypassing the dysfunctional trabecular meshwork. We have three generations of the Einstein. First is the generation one Einstein. It was launched in 2012. It is one economic stand made of preparing body titanium with a central movement of 120 microns, and it is implanted in flat scanner in the user angle. It reduces IOP by 20%. Now, generation 2 Einstein. It was launched in the year 2018. In these two states were preloaded in the injector, and it was easier to implant. Product coverage of spell scanner is there, and better IOP control and less dependence on the drop. In this image, you can see that on the left hand side is Einstein, that is normal stage stand, and on the right hand side is conical stand, that is Einstein injector. Snorkel safe Einstein, it is 1 mm size, while Einstein inject is 0.36 mm size. Einstein is a single device requires separate endoscopic imaging, while Einstein inject the preloaded injector first to 10, it is faster and easier. For Einstein, it is for the window is needed, while it is easier to learn the Einstein injector. This is the comparison between the Einstein inject and the Einstein inject W that we use in our hospital. We can see that the range is wider in inject W. It is 360 micrometer diameter. It helps to prevent the more deeper penetration of the Einstein and ultimately lead to more retention of the Einstein. Generation 3 Einstein, it was launched in 2022, which is known as Einstein Infinite. It consists of a 3 microscope wide range stand on a single preloaded injector. It started more outdoor segment and significant IOP reduction. Let's discuss our case. 72-year-old male patient came to our hospital with a chip complaint of invasion of listening of both height and ongoing AGM from elsewhere since 1 year. His uncorrected visual acuity was 6 by 24 in the right side and 6 by 12 in the left side. IOP was 17 and 16 weak AGM. CTM examination showed the refractive changes which were more in the right side compared to left side. Fundus was showing 0.8 CPR in the right and 0.7 CPR in the left side. OCPR level was suggestive of the early glucometer changes and measures by open arm gluconoscopy. Now, we can see that in on the pattern variation, there are scattered photomas in the superior quadrant in both of the eyes. This is a OCT image which shows the early glucometer changes. Patient was on parasite eye drop mode in both eyes. We decided to plan white eye cataract surgery, but the patient wanted to be free from anti-glaucoma eye drops. So we planned extend implantation with cataract. This is a short video of the Einstein. In this, you can see that 360 microns of the Einstein we have implanted. After the cataract surgery, after the insertion of fiber, we will use pyrotherapy to constrict the pupil. And first we will evaluate or visualize the surgical field. Then we will prepare Einstein device. We will advance Einstein device in the engaged chamber, and after the identification of the target site, we will inject Einstein into scan panel, and this plus of the is the sign of the better injection of the Einstein. After first we will insert the second Einstein and was the infective one and engaged chamber was first one. Post-operative, we got a visual acuity of 6 by 6 with 0.5 cylinder. And in post-op IOP measurement, we can see that the pre-operatively the IOP was 17 and 16 both 5 AGM. But after implantation of the IOP without AGM also, the patient was maintained IOP in the range of 12, 14 to 16 and 2 months post-op. Photo, treatment photo shows the patient in their place. Patient was very happy and satisfied. Thank you.
Thank you, Jay. So I think we want to question right now, these are the level of questions. These are the very much questions. Okay, we have Dr. Swati. Committee and commented that, because of visualization challenges, the two states of this is closer than it normally should be. And we should have been a little further apart, but there were some visualization challenges, so we ended up putting them just two blockers from each other.
How many years is it?
So, that's the question which I used to ask my neighbor also. And they have data of about 5 years plus, and they had more than 90% rate of medication or all better medication than for the case. Suppose they were on four drugs, they were able to bring them down to one of the drugs or medication. So they kind of think that the visual loss will be delayed and need for more invasive surgery will also get delayed. So they kind of are postponing on a bigger intervention and also postponing visual loss. It will also cheaper. So I think we can start and then we will have all the feedback.
And patient was getting classes in past 12 years, so the stable infection in past 2 years. And she had to keep a contact with this, but not happy with them. Already working for laser vision correction for cognitive problems. The patient has an uncorrected visual activity of 2 by 16 right time, with 1 by 16 left time. And she was putting her old classes with minus 9.5 diameter of square with minus 1.25 cylinder in 90 degrees, with a vision of 6 by 18 in right side. And left side she was using minus 13 spherical with minus 1 cylinder at 40 degrees, with a vision of 6 by 18 in left side. The best side visual activity, the patient was informing with minus 10.5 here with minus 1.75 cylinder, 6 by 6 parts in right side. And with minus 20 diameter of sphere, minus 3 cylinder, she was included to 6 by 18. On further examination, there was a myopia tested with vital or pressure areas, and she was diagnosed as a high myopia in right eye and a pathological myopia with an asymmetric myopia in left eye. This is the pentagram image of the right eye of the patient, which shows a symmetric bow tie pattern in the axis radial transformation map with a thinnest patchy of 476 microns and AC depth of 3.48 in right eye. The left side shows a again symmetric bow tie pattern on the anterior curvature map with a thinnest patchy of 490 microns and AC depth of 3.46 mm. The lesions map in the right side was not suggestive of any significant changes with normal CPI and D values. Again, in the left side, no significant ectasia or elevation were suspicious in the left side. Now, how will you manage this patient on seeing the refraction and everything? The first thing which must be coming to your mind is eye flares in the right eye as well as in the left eye. So, may I ask the question? Anyone, how are you going to manage this patient? Anything other than eye flares?
Yeah, so at this point, I still think we need one option. And I think you must have done global investigation to come to a point which is right. Yes. So yeah, at this point, I still think
So now we feel that if we further investigate the patient, this is IHS scan which shows chronic performance index, dysfunctional left index, and the quality of vision. This is the right eye IHS scan of the patient which shows a 9.5 chronic performance index and the poor DLI of 3.1 with a quality of vision index to 1.6 in right right eye. And when we see the left eye, the dysfunctional lens index was significantly poor, 0.54. On seeing the Shank analysis, it shows the exhibitions in the right eye, which are basically because of the astigmatism in the cornea, which totally adds up to the total internal elevation. And in the left eye, when you can see the internal elevations are significantly high as compared to the corneal elevations. So the total elevations of the whole eye are because of the internal elevations only. So now, is there any change in the management after seeing the eye rays of the patient?
So definitely this patient will not be happy with the eye color. Obviously, the lancing is more out. Because the main cause is the lens. Right, so if you're not going to address that, it is still going to have a lot of high order of patients.
So IRIS can be very helpful in deciding whether to do a dysfunctional lens exchange or whether to go for an ICL, because we can clearly see that the internal elevation is significantly high as compared to the corneal elevation. So we have decided to go for an ICL in the right eye and a dysfunctional lens exchange in the left side of the patient. Now, coming on to the sizing of the ICL. The biotech company has suggested us a size of 13.5 mm with a predicted vault of 511 microns. But we have calculated predicted vault with multiple formulas. This is the Environ-based glucose formula, which shows that with 13.2 mm of ICL, we were taking a vault of 764 microns, and with 13.7 we were getting a vault of 905. Again, the other Iron Master based formula shows that with 13.7 we would get a vault of 990 microns. With Gardiner and recently approved shows that with 13.7 we would get a vault of 1000, which is significantly high. So we decided to stay with 13 mm of ICL, and we did right eye dorsal lens, the left eye is functional lens exchange with A1 hydrophobic of -1 diopter. This is the intraoperative OCT image of the right eye of the patient, which shows a vault of around 600 to 700 microns. And on seeing the next day post of day 1, Environ image shows that the vault of 750 microns in the right eye of the patient, which is acceptable. Now, again, we have to treat the iris, which has significantly improved. It was 3.48 in the right eye, so it has improved to 7.45 in the right eye of the patient. And drastic change in the dysfunctional lens index in the left side of the patient, which has improved to 10. Previously it was 0.54. So after doing a cataract surgery or a dysfunctional lens exchange in the left side, there is a significant improvement in the real eye as well as in the quality of vision, which has improved to 9.6. The internal elevation was also introduced in the left side, but astigmatism still persists because we have implanted a -1 diopter of spherical J1. The patient's visual acuity has improved to 6 by 6 parts in the right eye, and from 2 by 18 she has improved to 6 by 9 in the left eye. And she was happy with the vision she got. That's how we managed this case. Thank you.
It's a very nice case, and especially when we already been thinking that the patient might be having a myopia. We are improving to 6.9 is a great thing. And iTrace is a really great, device, especially for people who are practically infected. So always the grading cornea is not the solution. So, Gaurav sir, if you can share your experience with BLS and exchange or practice lens exchange, what has your been?
So we normally repeatedly see this. So when we have a patient who has, poor vision, perspective vision is very poor, high myopia, and we typically think that this eye is probably amyopia. There's a lot of anisometropia, and we think that this eye is not good gain, not much visual gain. But what we've been seeing again and again is that on the retina, we see that there is nothing grossly wrong with the vision. So on the iris, if you notice that the lenticular aberrations are very high, and the disruption index is low, and the time is showing that cornea is mostly aberration, whereas the lens is showing phenomenal aberration. We typically don't go with a refractive surgery, we go with a lens exchange surgery, and we have found that there can be times there can be 2, 3, 4 lines of improvement. Many patients come to 6, 9 or even 16, and it's very gratifying. But on the other hand, it cannot be taken as a golden rule. There are patients, so sometimes you have an ALI which is very poor, like 1. But the patient having a vision of 6/9 with glasses that is quite comfortable. There I would not go with a lens, I would still go with a IPL or a practice if possible. Because sometimes there are heavy variations, but if everything is fitting in, poor vision, poor PCA, and lots of applications and poor, patients not, then definitely it's worthwhile, considering the dysfunction that is is very high.
And I feel, sir, the patient with very high IPR, they feel more comfortable with the human. And, the human, monofocal lens, they are quite happy.
Absolutely, you put a monofocal because usually these are minor lenses or something that you want to do much out of it. So only thing is that, I would not do a refractive lens exchange, and that's why we started calling it as a dysfunctional lens exchange. Because we would only do it when we were sure that the lens is dysfunctional and not allowing full vision to improve in spite of, doing a refractive surgery.
It can be proved the other way also, when after doing a cataract surgery, patient is not to have can see lot of glare, it can fight the right. And in such cases, due to a customized abrasion surface,
So for a pseudophakic who's not happy with it, due to what? Like, it could be angle alpha or something.
like this oil or trauma.
You can do that, but frankly, typically, I would not put a premium IOL to the refractive or something. If the corneal aberrations are very bad, we do an IOL for our guidance sessions also. And if you are going to do a trifocal or something, if the corneal aberrations are really bad, I may not give them a.
So my question was that in one of my case, I did a cataract. Really very good, but patient is just not that. So then I sent that patient when he was placed to for a high training and found provide preference. So it was the other way.
Right, sometimes you'll actually find a slightly better for this, you find a cornea with this good. Elderly patient, you may have this thing because they really ask, you put a dolly IOL, patient is still not happy. And then when you do a topography or something, you find that you corneal, the thing is, thinking and everything, asymmetric cornea, even that will happen to me. Actually, and then obviously, you think that, So now I actually do a topography for every toric eye patient. I will not do a topography for this part of my work now. We don't want to place any kind of asymmetric cornea and put a toric eye, for example. But yes, it can be done what you are saying, that we can treat the aberrations of the surface with a you can do a topography since we can correct it.
Thank you, and now the last case for today will be presented by Dr. Manindra. He is recently joined us as a fellow, and you credit to her for helping out with the review of this data in this particular HCC case as well. Please go ahead.
Everyone. So I'm presenting the case of Mr. or female who presented to the OPD first on 13th of January. The chief complaints of redness and pain in both eyes in 2 weeks, ringing sensation both ears since 5 days, and one type of since 1 day. Now she had a huge medical history. She's a known case of mixed connective tissue disorder since 20 years. Known case of rheumatoid arthritis since 15 years, hypothyroidism since 12 years, hypertension since 2 years, and she's a newly diagnosed pre-diabetic. She was already on tablet esothyroxine 50 mg with hypertension 60 mg, along with other medications for thyroid hypertension and diabetes. She was also history of taking hydroxychloroquine earlier. On examination, this is the right eye of 6/9 with correction 6/6, and the left eye of 6/5 and correction of 6/6. Pressure in the right eye of 20 and left eye of 13. On slit lamp examination, both the eyes circumpointed congestion was present, cavities were present, AC sensor 2+, flare, and occasional visual sensor was seen. Now, on fundus examination, the disc and macula were normal. There was slight venous dilatation, tortuosity, and no treatment lesions were seen in the periphery. OCT macula was normal. She was diagnosed with acute and serious uveitis, and the cause was to be found out, and was started on medications accordingly. And then she was referred to a rheumatologist and ENT specialist. Now, according to the investigations advised by the rheumatologist, ENT specialist, and they also referred the patient to a neurologist. Multiple investigations were done. On audiometry, bilateral moderate sensory and hearing loss was seen. On LFT was slightly delayed, SDMC was 6.6, ESR was 100 mm, CRP was normal. On urine looking microscopic examination, 40 to 60 pus cells were seen, and on urine culture, E. coli was found. BP was raised, NCT had an MRI that not show any significant finding. From ENT opinion, the diagnosis of acute severe tinnitus, immune-mediated was made, and rheumatologist's diagnosis was atypical Cogan syndrome. The patient also had UTI at this stage. She was admitted and she was started in IV with hydrocortisone 1 gram for 3 days, followed by tapering dose of prednisolone and IV meropenem 500 mg PID. She was also started on methotrexate and folic acid, along with her medications for tinnitus and insulin was also started as we were giving her methylprednisolone. So in February, when she presented with uveitis was in the resolving state. Then in March, we had a recurrent episode of uveitis again, along with this complaint of fever, cough, and rhinitis. On investigation, it was found that the patient had pancytopenia, hemoglobin was 8.7, against 1700, and platelets around 1 lakh. ESR and CRP both were raised. Rest of the investigations were within normal limits. So now tablet azathioprine and methotrexate, both of them were stopped, and prednisolone was continued. And gradually, the patient was restarted on methotrexate when the blood work started to improve. On 12th of May, when the patient presented to us again, the radial uveitis had resolved completely. So the patient was maintained on moxifloxacin plus dolutegravir, low dose steroids. 5 days later, the patient presented again with complaint of pain, headaches, and watering in both eyes. With the pressures of 37 and 25 and 50 in both the eyes. Again, there were signs of anterior uveitis. So this time of fundus examination, mild perivascular sheathing was seen in the temporal quadrant in the right, as can be seen in the picture. So this was diagnosed as a flare-up of acute anterior uveitis. So according to the rheumatologist, the patient was switched to tap mycophenolate mofetil 500 mg to tap BD, and again tap prednisolone 40 mg was started in tapering dose, and along we gave her hydrocortisone along with anti-glaucoma drugs also. Now on 11th of June, the patient was in a resolving stage of anterior uveitis. However, she developed a lower lip rash, which was first in the left leg, which progressed to the right leg in 1 week. So a dermatologist's opinion was taken. They had a differential either of mycophenolate induced rash or herpes zoster. A smear test was done, which was even positive for herpes zoster. So the patient was started on that vancomycin. Now the patient was asked to stop mycophenolate. So she has stopped mycophenolate 1 week before presentation to us. That was on 16th of July. So 16th of July, she had again uveitis. So in this presentation, along with anterior uveitis, there was marked perivascular sheathing in the nasal, temporal, and inferior quadrants in the right eye, along with snowballs. And in the left eye also, very mild perivascular sheathing can be observed. I don't think it's visible in the picture, but it was there in the STQ quadrant. The patient by chance presented today also. So in this stage, the uveitis is in the vasculitis is in a resolving stage. The snowballs are much less than before, and the perivascular sheathing has also decreased. And in the left side, the perivascular sheathing has improved. So the further plan, according to the rheumatologist, is to start injection or rituximab, and she is being investigated for the same. So now, what is Cogan syndrome? It is a very rare autoimmune disease that is mostly seen in young adults, and it is characterized by inflammation of the inner ears and the eyes. And it presents with vestibular auditory dysfunction and interstitial keratitis. It is basically a diagnosis of exclusion, and systemic manifestations are present in 30 to 70% of the cases, which are related to the vascular involvement of the disease. It can be typical or atypical. So typical Cogan syndrome has two main manifestations. First is non-syphilitic interstitial keratitis, which has been described as if there is a granular corneal infiltration near the limbus with vascularization in the later stages, along with vestibular deficit, which presents with features resembling Meniere's disease, with sudden episodes of nausea, vomiting, tinnitus, vertigo, and progressive hearing loss that usually progresses to deafness within 1 to 3 months if not treated. And these two manifestations usually appear within a period of less than 2 years. Now, atypical focus is present when either if there is an inflammatory ocular involvement other than interstitial keratitis, and or if there is typical ocular involvement with interstitial keratitis associated with features of cochleovestibular and auditory symptoms which are not characteristic of Meniere's disease, and or if there is a delay of more than 2 years between the onset of ocular and auditory symptoms. And with atypical focus, systemic features are more frequently associated. The ocular features in atypical focus that can be present are conjunctivitis, scleritis, uveitis, papulitis, optic disc edema, central vein occlusion, glaucoma, and retinal vasculitis. The systemic features in general can be fever, myalgia, headache, insidious arthritis with can be there along with aortic insufficiency, pericarditis, arteritis. Polyarthralgias may be seen. Few patients have been described in literature having atypical focus associated with rheumatoid arthritis and ankylosing spondylitis. Neuro symptoms can be hemiphagus, hemiplegia, aphasia. In GI, diarrhea, abdominal pain can be present due to mesenteric arteritis. Cutaneous symptoms can be non-specific erythematous or urticarial rash, purpura, nodules or ulceration of the lips, genitis or mouth, and pyoderma gangrenosus. Now, management basically depends on the severity, but the mainstay of management is high-dose corticosteroids for systemic vasculitis. They are the first-line drugs. If an improvement occurs, then they may be favored over 2 to 6 months. If improvement doesn't occur, then the patient will require additional immunosuppressive therapy like methotrexate, eventually cyclophosphamide, and cyclosporin A. Now, rituximab has been shown to reduce the medications used to control the systemic manifestations and help avoid cochlear implants or deafness in certain severe cases. However, it was not used as a first-line drug till now. This is a study which was published in JAMA Ophthalmology in 2007. It showed 3 cases of patients presenting with atypical that had uveitis. At the time of presentation, these patients already had complete hearing loss, with 2 patients already having undergone cochlear implant. So the patients were already in an advanced stage of the disease, and they were already on the immunosuppressants. So they were treated with topical steroids and cycloplegics for the uveitis, which resolved this. This was the case where they took 32 cases of typical plus atypical Cogan syndrome. This is mainly to describe this table describes the outcome of the study. So as we can see that more patients develop auditory dysfunction leading to deafness, even after onset of corticosteroids, and in some cases even immunosuppressants. And some patients also develop decreased vision acuity, and even a few patients develop blindness. So basically, the auditory prognosis is very poor in such patients, and it may lead to deafness in 1 to 3 months. This is another paper that discussed 7 cases of typical and atypical focus. They are 3 typical and 4 atypical. They received local and systemic corticosteroids. First, then on clinical follow-up, there was recurrence of audiovestibular symptoms in 4 patients. Then immunosuppressive therapy was started, and the hearing was improved in 3 cases and visual function in 2 cases. After that, also 1 patient developed total right deafness 3 years after the onset. So the treatment strategies are not clearly defined, therefore early assessment and treatment for systemic inflammation are needed to prevent life-threatening complications. Thank you.
So very nice case. I don't know if I've seen the case of Cogan syndrome. So what is the percentage, like incidence rate of this Cogan syndrome?
Until 2023, there were only 250 cases of COVID have been reported.
That's a pretty rare. So what
Yes,
you
sir.
see, like, percentage case. Just one small observation. Right from the beginning, the patient was given topical antibiotic and steroid.
So what would, like, why antibiotic was used? Does she reason for being possible? Like, was just for a secondary trouble?
So the second problem, the patient eventually, she had the relation was also for the relation was there.
Right.
Yes, yeah. Prevent any secondary bacterial. I had a question on, what is the cause of IST, and why, like, the hypertension antibiotic, so what were your movements for fixed findings? Was it vaginitis or is it,
I don't think colonoscopy was done, neither was the, glaucoma opinion was not sought. I think at that point, the main thing which was, leading us was the systemic, complications. So it was transiently that the patient had to diabetes. Then was the IOI.
they had the IST, initial 2 times she had the first presentation, first flare up, the IOP did not rise. The only when the patient presented with a single flare with a high IOP also rose and first she presented with vasculitis.
At that point of time, actually, what was happening was the rheumatologists were having a tough time in, realizing her on the immunosuppressant because of issues with transaminases and all those things. So they had to stop methotrexate and, azithromycin at that time. And at that time, the UVIs came back to the, rebound. So at that time, we not never treated her very intensively with the steroid, topical steroid. So we had to kind of fill in at that time. And there was a period of, IoT rise which we had at that time. But it settled down once we tapered off the steroid and gave her topical. But yeah, we didn't do colonoscopy at that point.
Very, not sure how to find it. So at that time, we don't even suggesting for very long. And in the treatment, she developed a virus, began on my leg. That is actually still under, they have done a skin biopsy, which, the report is still not found.
So the thing is that I think initially the dermatologist, it was using active. So the dermatologist made diagnosis of herpes zoster with a query of positive than, that's what he told. But when it became bilateral, again, zoster, usually we don't see, kind of rash bilateral. So then the rheumatologists were also, think that, what are they dealing with? So then they considered what they are considering currently is actually mycophenolate induced rash, not viral at all. So
There's a fire leader,
would have been ideally done, yeah, but again, the systemic problems at this point of time, I mean, they got so much importance because, she was having such grave systemic issues that she was with us just, for a very limited, very, follow-up. So, because she was back and forth going back to the rheumatologist, and getting admitted in the hospital for various emergencies, so it was difficult to kind of manage her, glaucoma also, and, investigate her therapy for the glaucoma and do a PPR for doing. Yeah. So I do agree that, maybe on hindsight and retrospectively, maybe doing a PPR, because we can see iris atrophy much more marked in the right eye now. So, it has set in. So maybe a doctor would have been a positive, viral, kind of etiology would have been a positive. And ideally, a PPR could have helped. Yeah, it is given us nightmare. Thank you so much, Dr. Thank you very much. And to that, I gave this data to her at 10:30 a.m. today. So this is the output, and we excused her from the OPD today because we decided to share this case report today, and she managed this in just about 4 to 6 hours of work. That case report. So I was very committed with her. Amazing. Okay, so with this, I think we call it a day. It's been a long meeting, and thank you so much, everyone, right from, Vivekananda, Nekale, Jonas, and, from the we had Dr. Priyanka and Dr. Vivekananda here, and of course, from, Anand Nekale, Dr. Pansi, Dr. Sundar, Dr. Chirag, thank you for joining us. I can't thank you enough, and Dr. Uji, we going from. And so thank you for joining us, and also thank you, to the pharma, promoters from healthcare, thank you so much. for supporting this initiative, and thank you for making this meeting a very nice interactive scientific session, and I try to also dinner now. Yeah.